So hi, I am representing table 4 and I have happened to gate crash your round table here. I was not part of the panel and I'm presenting today. So our table we discussed about health, community health AI upgrade kit, and we are looking at equity among people. So I am a radiation oncologist. I work in a public health medical college in Bangalore Medical College to be very specific. And I work in government policy making and all those things because I work for the government. So that's how I went to this table, and because of WIPIN as well. So, so we were discussing about community health AI upgrade kits. We are looking at this Basti Dawakanas. Yeah, so that's what we are looking at. So we were 5 of us with us. That's what we did. Oh, these are all our profiles. We had a good mix of all types of industries so that we had good inputs, actually good discussion. In fact, they were asking us to go out. It's a break time, you people go, we were sitting and discussing. So we had a different various views. So all of us here brought a different thing to the table based upon our relevant experiences. Ivita ma'am, she spoke about structure, equity and last mile because of maternal background, health, MCH health is what she did. And we discussed a lot of things, how it can be standardized and things. Then I talked about, because I'm very interested, incidentally I become a doctor in radiation oncologist because I wanted to be a technologist. So that's why data capturing is one thing which is I'm very passionate about. So I was just looking at how we can capture data from the baseline. So something like that. So we were looking at some models. In fact, something as simple as a scanning machine. There are some hospitals who are implementing EMRs across the country who are just using a scanning machine and using various models just to make this unstructured data into structure. So that is one of the things what we saw. Then of course Vipin we have, who is very good at validating any data set for that matter. If you sit with him, I think you can ask him to explain the idea in 1 minute, 10 minutes, 1 day and 1 month also. So he'll explain it that much in detail. So that is what we did. So he was very specific about, let us deploy, validate it. We need to validate, because without validation, down the line, like our pharma industry told, if it fails in the beginning, there's no point going up all the way, right? So something like that. So validation is the key for our kind of community-based practices. Pramila, of course, she is from an NGO background. She has gone to the ground levels and see, because she's a doctor by training, but again, we know what happens, what we are trained for and what happens on the ground are totally two different things. So that is one thing which is a very, very important kind of thing. So a single window screening, because the number of activities an ASHA worker does at the community level is very huge. So humongous. So any new policy or anything government wants to do, it is going to go ultimately rest with them only. So we need to look at how we can reduce the friction for them. Then Sham, our cardiologist in the team. So we are looking at NCD capital, India's NCD capital. So you can see cardiology, Indians are more prone for cardiac illnesses. So that screening is very important. So we need to have some basic screening done. In fact, a lot of this is already available there. It's just the thing is, we just need to capture and leverage that data what we have. So as a NGO field partner, we were thinking of adopt a Dawakana kind of thing, which Madam was telling, and which I think that's the only way how things work. So unless there is some adoption and some NGO involved, public healthcare is it's not working without help of NGOs. That much I can tell you. They can actually facilitate use of them, but I think NGOs are the key people there. From the healthcare center, I think ASHA workers are the key from the government side. So when we mentioned about how do we deploy a standardized community thing, so we were looking at some basic hardware. We need to have a stable, we need to have electricity there up and running, and we need to have some backups also as for that. And some basic hardware so that internet connectivity is there, and you have some hardware to transmit whatever data you are capturing. So, and clinical decision support, because as India, we do not have clinical acumen at the grassroots levels. So clinical support systems also help. Not for all maybe, but at least we'll be able to triage these patients in a different way, and we can see who needs access to healthcare early. So training and handhold. So always in public infrastructure, we think we need to have this training in place, because otherwise we will be just doing, it will be like an eyewash or a political program. Every 5 years, some new poster will come. It will be something like that. So we need to look at training and handholding. So periodic audit and course correction is also required, because we need to learn from our mistakes so that we go for a long run, long haul. So we looked at all the things, the acute, what is present in the Basti Davakhanas, then policy gap, what it can do, what's the impact, everything. I think their AI models have very nicely captured most of the things what we wanted to say. I don't think so we would have done justice if we are asked to make the same presentation. So this is what is shown in our national programs also. So this also shows that community is very important. Community-based programs are very important. So we need to look at all these frontiers. Data governance is high because, so all that, I was just discussing over lunch with somebody today. So what is normal? I think in the break we were discussing. What is normal? So this normal is got from Western data. We do not have any Indian data to certify our normals. So every time American Diabetic Association raises their bar for cutoffs for diabetes, we get that many patients enrolled as diabetics. So that is one thing which is a skewing factor for that. So we can do is like as other tables have told, I think Telangana state can lead, and of course all the other states will follow. So this is a timeline what we think. So we should always, as a community-based, and I think data capture through a ABA ID linked thing is going to stay, and I think it has arrived. A lot of records are happening. Government is also working phenomenally on that in the background. So I think we need to be inclusive of that whenever things are getting done. India is a very diverse country, so we need vernacular languages, other things. We have many, many models which are already tried and tested, which we can use. And of course, then we need to have a continuous response, the recertification of all the models deployed. I think in the government, I think MATI is also looking at some making deployed models as well. So of course, all the stakeholders, government, private, that's the only way I think we can go. And I think academia also helps. Our National Medical Commission also has a lot of inputs into community health as well. So that is what we're looking at. So these are all the successes what we can look at in the coming years if all the things are done. So if you see here in all the tables which presented, only one of these were highlighted. So if you see community, we can reach out at multiple levels. I think it's a largely deployable model. So the recommendation is we deploy a single standardized ABM compliant upgrade kit. We have a basic hardware which we can use for triaging and disease report, more commonly for our NCDs and handhold training for the long run, and built-in audit loop. Of course, we need to have a human in loop. This is what we want to do.